Thank you very much, Delphine, for introducing this today's journal club and all the organization. Again, apologies for the delay. So, Professor Mishra, can you hear me?
Yes, I can hear you loud and clear. Am I audible?
Yes.
Yes, we can hear you.
Perfect.
Yeah, so we won't delay further. We'll just allow you to share your screen, and you have about 15 minutes to share with us your paper and your findings, and then we'll take it on to discuss and with all who are present in the meeting. So the floor is yours, Professor.
Thank you, and I really apologize. I think there was a mix-up regarding time and time zones. Here it is late night in India. But thank you to GASOC for giving me this opportunity to talk about one of the work which is very close to my heart. And so I'll just share my screen and then take it. So what will happen is I have not tried to just put down the paper as such, but I have tried to put in some context before we actually go into the research of it. And I think that will itself emphasize on why we did this and what we got from this. So is my screen visible?
Yes, I can see your screen. I think others as well should be able to see it.
Okay, perfect. So, so if you can see, the title of my study was Gasless Laparoscopy, taking minimal access surgery to low resource areas. And I'm presuming that most of people here are residents or trainees in surgery. So am I correct, Alliance?
Yes, mostly trainees who have attended. So that I think most of them are trainees.
Perfect. So basically, I don't have to go into the details of the nitty-gritty of the surgical things. This research was done by a group of people who are rural surgeons, academic surgeons. There's some engineers, there's some designers in the team. So it's a team which spans across 2 continents. Half of it is in UK, in University of Leeds. Then in India, we have people like me who are academic surgeons who work and teach at a city medical college. And then there are some rural surgeons like Dr. Ghani. The context of this study was that we all know that minimal access surgery is better than open surgery. There is, I don't think, any doubt about that part. And there has been n number of papers on that. There have n number of systematic reviews and meta-analysis. They all have proven that minimal access is better than open surgery. And mainly this superiority is around better or a faster recovery rate, faster return to home and return to work, and also less complication rates. So if it is like that, my question or our question to our mind was that who deserves these benefits more? Is it an urban dweller who is rich, who can easily earn his bread? So what we see generally in cities in India or any middle income country or even in developed countries, that you do minimal access surgery, you discharge the patient on day 1, and he goes and rests for next 4 or 5 days at home. So actually, we are not benefiting the whole society or the system as such. Whereas if you see a poor person or a person who is living in a far-flung areas where when he goes and get a surgery, and let's say if he gets an open surgery and he loses 5 days of wages, he is not able to go to his fields, he's not able to cater to his livestock. So that is a big problem, especially in a low middle income or a poor countries. But the whole thing is so flip-sided that most of countries, most of LMICs especially, the minimal access is accessible to mostly people who maybe don't need it as such. So that was one concern which we had when we were traveling across the low resource settings. So what we realize is that MAS is not readily available in far-flung areas or rural areas. So people are forced to undergo open surgeries, right? And mostly because they cannot travel to cities for this, and they know that it will be a complicated surgery and a long surgery. Many of them, they choose not to get operated. They avoid the surgery, they prolong the surgery, and that leads to a morbidity cycle that happens. The reasons why MAS minimal access is not readily available in far-flung areas, because this procedure has a high recurring expense. The supply of consumables, especially gas in those areas, is limited, and people do not want to waste on transport cost and other cost just to bring in gas or other consumables for the surgery. Plus, when we have to do a minimal access surgery, it generally is done under general anesthesia. And then if it is done under general anesthesia, and there are a lot of parameters which changes with minimal access surgery, so we require a very close monitoring. So we'll need an anesthetist, we'll need very high sophisticated monitors, which generally are not available in these settings. So that is another problem. And if you realize that in rural areas, many of the surgeries are done under spinal anesthesia or regional anesthesias. So that again is the flip side here. So this is the background on which we built. This is just a small video, which just to put everything in perspective.
The rural areas have limited resources and infrastructure for minimally invasive surgeries. The gasless laparoscopic surgeries, or GILS in short, was developed to meet the needs of the patients in rural and it makes laparoscopic surgeries possible under spinal anesthesia at a very low cost. There is a great potential to take this to the remote and rural areas to prevent higher morbidity and mortality that are associated with open surgeries. The Maulana Azad Medical College at Delhi did a randomized controlled trial to see how this compared to the traditional laparoscopic surgeries. 100 patients were randomly allocated to undergo either gasless or traditional laparoscopic surgeries, and several parameters were studied. Results showed that gasless group had better intraoperative vital signs and marginally less operating time. There was no significant difference in the other parameters, although the pain score were marginally higher in the gasless group. Literature agreed with better hemodynamic parameters and also had other advantages for minimally invasive treatment for lower and middle income countries. The lower cost and isobaric system make this even more relevant during the pandemic.
We started comparing laparoscopy and gasless laparoscopy. I started seeing these procedures done. So in conventional laparoscopy, what we need is something for vision, which is telescope, light source, a monitor. We need a space to work in. So generally we use carbon dioxide to create that space, that cavity for us, which is under high pressure. And you realize that both carbon dioxide and the high pressure which we are using, they are responsible for 99% of the complications which occur in minimal access surgery. So that is why they require general anesthesia. That is why they require strict monitoring. For gasless, we would require vision, so which is the same as in conventional laparoscopy. We require space, but here we are not using carbon dioxide, but we are using a kind of a retractor. So if you see here, this is the retractor which goes to the abdominal wall, under the abdominal wall, and then you pull it up. So this basically acts as a retractor which creates a space. And now this space is isobaric. This is the pressure is just same as outside. So the complications like decreased venous return, the problem of the diaphragm, all that is negated. So these surgeries can also be done under regional anesthesia, like spinal anesthesia, because the rest of the part where you're not putting this appliance is not getting affected. This device was already there when we started the study in WHO compendium of innovations to look out for in low resource settings. So it is a very well validated device which we started using. So in 2016, I attended a rural surgery conference, and there is the first time we started talking about it, that we need to take this up and take it forward. So we made a kind of a working group. So what we thought is that if we want to work on this device, we need to answer some things scientifically. So what were the main gaps in this device? Because there was no, at that time, there was no formal evidence available that Gasless is better than open surgery. Okay, so but we realized that ethically we cannot design a study where we are comparing a Gasless laparoscopy to an open surgery. So that's why we decided that okay, we will do a non-inferiority trial where we'll try to compare it with the conventional laparoscopy, right? But when we are doing it constantly, the main context is that actually we are comparing it with open surgery, because in rural areas, that is the competitor to Gasless. Another thing for us was to redesign the lift device and to make it better, lighter, and maybe cheaper. And then the third part was around training of rural surgeons. So my task as an academic surgeon was around the first theme, that I had to design a study and maybe compare this device or this technique with the conventional. So we did that. This study was funded by Harvard Medical School, who donated this lift device to us and also supported the study. We took ethical approval from the internal college ethics committee. We planned it like a non-inferiority study, as already mentioned. So what we did is it was a single center, non-blinded randomized controlled trial, which was conducted in a teaching hospital in New Delhi. Inclusion criteria were all the patients who require elective laparoscopic general surgery for either therapeutic or diagnostic purposes. We excluded any patient with ASA score more than 3 or body mass index of more than 28 for this study. Any case which require multiple procedures intra-abdominal, especially which are in multiple, more than one sector of the abdomen, that were excluded, and any history of previous abdominal surgery were excluded. Then all these patients were randomized into 2 groups. The randomization was done by a table of random numbers by computer generated method, and the allocation was done by sealed envelope technique, which was allocated at the time of surgery. Mainly 3 procedures were performed: cholecystectomies, appendectomies, and diagnostic laparoscopies. Sample size, when we calculated, so for a 80% powered study, the sample size required was 78. So we decided, just to circumvent the dropouts, we decided to include 100 cases, 50 in each arm. So the 2 groups were the same anesthesia was used. They both had general anesthesia, and just in one group, which is the conventional group, COL is the conventional group that used carbon dioxide, keeping a pressure of 10 to 12 mmHg, and the other group used the Gasless technique using a stand laparoscopic positional device, which is shown in the figure here. The primary outcome for the study was operative time, which we wanted to compare, but we also did measure intraoperative vital signs and any changes in it, and postoperative pain, surgeon satisfaction score. So these were the main parameters which we recorded. This is the consort diagram of the study. So total, we enrolled 133 patients. We excluded 33 because they was not fitting the criteria. Then 100 cases, we randomized 50 each. Thankfully, there was short follow-up and there was no dropouts from our case. So we were able to analyze 50 in each arm at the end. Demographically, both the groups were comparable. There was no significant difference between the 2 groups. And so we can very safely proceed with the studies. Procedure-wise, There were, in each group, there were 40 cholecystectomies, appendectomies, 7 and 3. So this was by design that we stratified the procedure so that both the groups have equal number of cases in a particular system or procedure wise. So this is by design. Don't be shocked at how come this is exactly the same on both arms. Then comes the results. So setup time was kind of comparable in both the side. Operative time was again comparable in both the limbs. This is the main area where the variation started coming. So the vitals and the variation of vitals, we realized that gasless technique is much better in all the limbs, especially the EtCO2 levels. So this is one significant finding which we found, which was not there in earlier papers. Mainly they talked about operative time and other things. But this is what we were able to prove, that hemodynamics of the patient are much better in gasless procedure. Pain scores, we found that gasless has more abdominal pain, maybe because of the retraction, and maybe also because we use slightly bigger incision. In a conventional laparoscopic surgery, we generally use a 1 centimeter umbilical incision, but here we are using 1.5 to 2 centimeter incision at the umbilicus. Maybe that is the cause, but yes, umbilical pain was slightly more. But just focus here, the maximum pain, which was right after 6 hours in both the groups, it is kind of same, and it is less than 4 out of 10 scale. So the pain was not severe at all. So whatever slightly more pain is there, the pain intensity was not severe, but compared to conventional, yes, gasless had more pain. We also measured the shoulder pain, which is a problem associated with gas surgeries because they cause irritation of diaphragm and they cause shoulder pain. So again, a very mild pain. The maximum reported was 1 out of 10, which was there in conventional. So here, conventional fared poorly as compared to gasless. If you see the analgesia requirement in both the groups, there was no difference at all. So both required hardly any analgesia. There was no difference. So average analgesia, if you see, the p-value is more than 0.31. So this is no significant difference. Wound infection, hospital stay, they both were comparable in both the groups. This is the surgeon satisfaction. So what we did is, right 30 minutes after the surgery, we asked the surgeon to rate the experience of the procedure on a scale of 10. So they started scoring. So initially we were getting scores of 3 and 1 and 2 and 4 and all that. But as the number of procedures started growing, the satisfaction score starts growing. So this was an indicator of learning curve of this surgery. So right after, if you see 10 cases, the satisfaction score of the surgeon is more confident, the surgeon is more comfortable with the technique. So it shows us that maybe this surgery also can be learned easily. And 10 cases is the learning curve figure for this surgery. So what we concluded is that gasless laparoscopy is a non-inferior alternative to conventional laparoscopy in terms of operative time and pain. The stand positioner or the device which we use, it offers exposure comparable to traditional laparoscopic surgery and the surgeon satisfaction. Gasless scores better with intraoperative hemodynamic stability, and it is safe and can be easily mastered. So we advocated it for its wider use in low resource setting to extend the benefits of minimal access surgery or open surgery to selective patients in population. This technique, if implemented, can revolutionize rural surgery and can achieve the goal of safe and affordable surgery for all. So this paper is published in Journal of American College of Surgeons, which has a very high impact factor. So it's pretty validated and pretty talked about topic these days all across. That's all is for the presentation. I think we can take questions now.
Okay, thank you very much for your presentation. Very interesting article and research to hear about from India. I think that's where this research was done. So I think I'll open the floor to the participants to see if there are any questions, any comments they have, and just to about your presentation and also the research that was done.
I think there's a question on chat, Rima Patel, I think from Edinburgh. So the question is, are there any postulated theories for slightly increased wound infection in gasless laparoscopy? Also, what are the financial differences between the traditional and gasless options, just for organizations or departments that want to put together a business plan? Very, very good question, Rima. Thank you for that. First question is, we did not found any significant difference between wound infection gasless and traditional one. So that answer, I don't know. Yes, in the figure you might see 2 and 1 theory, but they both were mild. That's the reason, maybe because we are using a bigger incision. Maybe that's why the wound healing problems are there. About costing, it was not part of this study to analyze cost between the two arms. But right now we are working on a systematic review. Basically, a team from Leeds only is working on that paper. I think very soon we'll be able to give you a very solid answer. Outside research realm, if you ask me, because there are so many things we are able to cut down on gasless, that costing, I'm sure, will favor the gasless. How? When we are not using gas, there's no risk, there is no fear of leak from the ports. So that is a one big expense, that every second, third surgery we need new ports because they start leaking after few cases. So here, because there's no risk of them, we do not need very sophisticated ports. Rather, in rural surgeries, I have also used just a piece of tubing, which like a simple abdominal drains, because we just need a conduit, we just need a portal. It need not be any sophisticated one. And many times when there is no ports, we can directly also introduce the instrument through the incision. The only fear is, especially with the telescope, that it will get soiled again and again with the wound, the surrounding. And then there's a reduced cost of gas. There is a reduced cost of anesthesia requirements. So all those things are there. But yes, again, I'm saying we have to document it. We have to study it in a research format. Then only we'll be able to tell you conclusively.
Thank you.
Yep.
I say, as we're waiting for potential other comments from the participants, Prof. Mishra, I would ask, do you feel you are on a trend of potentially influencing minimal invasive surgery in high-income countries just from the fact that you are potential gasless might hopefully prove to be either non-inferior or even equal to laparoscopic surgery?
Yes, so I myself am a laparoscopic surgeon. I perform a lot of my surgeries laparoscopically, which is the conventional one. I don't think gasless, there are many things. So the context is very important. We do not want the gasless to come into the urban high sophisticated, like teaching hospitals or those centers. But for basic surgeries, if you see the eligibility or inclusion criteria, we did not include very obese patients, because when the abdominal wall becomes very thick, it becomes difficult to retract it. Okay, in our surgical training, we all have realized that sometimes it is very difficult to retract abdominal wall, sometimes it is not. So I think these are the situations where it's still the gas would help. Because what happens is, when we inflate with gas, it makes a spherical kind of space. So it also pushes away the abdominal viscera, the bowel, away from the field. Whereas if you're lifting something, you're just making space on one direction. Okay, so again, there's some limited space, it is still there where you're not able to work. Okay, so that is why for majority of basic surgeries, which I can, as a concept of rural surgeon, they should be able to perform most of the surgeries, and for the complex surgeries, they can always refer it to a higher center. So surgeries like appendectomy, surgeries like diagnostic laparoscopy, I think the biggest role would be in diagnostic laparoscopy. Why a patient has to undergo a full abdominal laparotomy when you can just insert, you can make a 2 centimeter incision, put a scope inside, just look what is happening, and that is done. So for that, patient need not undergo a laparotomy. So there is the main utility of this procedure. Okay, so I think the context is again very important where we are talking about it.
I'm actually it's very interesting that you are focusing on the those rural patients in need and not trying to design something that will go further, because then also it probably remains affordable to them, because the more it reaches to me, the urban areas, and it becomes a more expensive procedure, so it loses its value for the core population. Leonid from Cameroon is asking, did the indication of surgery was chosen, or is it just the surgeries that you found available? Did you choose the procedures for which you do gasless laparoscopy?
So it was defined in the protocol that these will be 3 major procedures which will be performed, and as such, these are the basic surgeries which we perform. We did not use included complex laparoscopic procedures like bowel resections or malignancies. This was by design.
Great. Okay, well, before we move on to the next presentation, just waiting to see whether there will be any other questions or comments. Mine will be, I'll share that in the country where I did my general surgery residency, there was a study about using air in laparoscopy instead of carbon dioxide. Is that what we use currently?
Yes,
correct?
yes.
What's your thought on that? It's slightly different, but that as the context was, it was used in a rural hospital for more than 20 years, and the fear was that because it's not we're not using CO2, we'll get explosions or many other things.
Yes.
But the retrospective look, showed it will work. So, any experience with air insufflation?
So no, we did not. I have no personal experience with air, but yes, the main concern when using air, which is not medical grade, typically we use a gas which is a medical grade gas, which means if we are using CO2, that means it is carbon dioxide only, and there is no mixture of other gases. If you are having gases like nitrogen, which is not very good for body because it can dissolve in blood and then cause bubbles. If it is oxygen again can cause blasts and combustions, and then other gases which might be there in air. So that becomes a risky thing. But yes, I have read papers about using simple those pumps of air pumps and being used in laparoscopies. See, in rural settings, again, we cannot say what is good, what is bad. I think overall, if we start seeing the picture overall, many these kind of hacks are used, just to get the work going. So, yeah.
Yeah, well, thanks very much for sharing your experience, and I'll probably share with you the article and our experience from residency program. I'm sure you'll be very interested to hear.
Sure. That will be. I'll be a pleasure. Yeah.
Again, I think as a closing for the participants, for me, especially as aspiring, I say low middle income country research, I'm working on some papers. What I'll note from your paper is really you responded to a problem that concerns the patients you see every day, the rural patients. You brought in, you had an idea, but you went forward and brought in the necessary collaborations, bringing together a laparoscopy surgeon such as yourself and researcher, an engineer, anesthetist, because you had to convince them probably to do spinal, and find out from the WHO what innovation you could use was, multi-disciplinary work to get this paper going. And then good quality research, because again, going down your paper, good randomization, an approach to proving non-inferiority to what is standard of care currently. And then, well, as much you said that you're going to stay focused on the rural populations, but you are very much able, if you wanted to push it higher, to try to influence even current practice. But interesting to me is that as a rural surgeon, you are focusing to develop technology that suits your population rather than export it, but you could if you potentially wanted to. So that's my closing comment regarding your paper. So I hope many of the participants have learned from it and can be able to take the example, also to take their research ideas to the next level. It looks like there's a last question. Do we have an idea of how widely gasless laparoscopic surgery is being used currently?
Yeah, so right now we are very aggressively implementing it across rural areas. And so currently there are around 6 states in Northeast India which are using this technique. Rather, you'll be glad to know that even day after tomorrow, we are again traveling to a rural site just for the training workshop on gasless. So right now, if I say in India, there will be around 10 to 15 centers which have started using this as the sole procedure for emergencies which require laparoscopy. All are obviously rural centers. And also our training program, so many of these are just, they're not even surgical residents or surgical trainings. Right after their graduation in medical school, they can start doing these procedures. So that is, so we're trying to do it. Again, focusing only on basic procedures, basic skill sets, and that's how we have designed the training program.
Okay, great. Thank you very much. I'll hand over to Delphine to proceed with the second part of the presentation, and I think she's back and ready to take it on. Again, Professor Mishra, thank you very much for joining us, and we hope to have you on more for our journal club. So Delphine, the floor is yours.
Yeah, thank you. Thank you very much. Thank you, Delphine. Thank you, Alliance.
All right, so I'm just going to go on to the next article that we'll be discussing. Again, apologies for Professor Papali, he wasn't able to make it, but we're going to make this more of an interactive discussion on really the implications of this article and how we can actually move forward and actually optimize low middle income country research. So I'm just going to share the presentation. Let's see if I can get it. There we go. Can everyone see that? Just say yes if you can see it.
No.
Yes, we can see it, I think.
Okay, lovely. So I'll just put it as full screen. Okay. So it's quite a long-winded title, but I'll go ahead and say it. So it's an article which goes through the geographic, subject and authorship trends among low middle income countries based scientific publications in high impact global health and general medicine journals. And this is over a 30-month bibliometric analysis. So this was published by Ghani et al. And I will be presenting it as a representative of GASOC. So in terms of the article, the introduction was really setting the picture in that there's an overrepresentation of scientific publications from high income country and also upper middle income countries. And there's an underrepresentation of low middle income or low income led research. And so this article was, or the research was used to actually find out, you know, what is going on, where is the research really happening within low middle income countries. So there's a lack of knowledge regarding the geographic distribution, the authorship, representation, and also the subject trends among low middle income country based scientific publications. So in terms of the methods, it's a bibliometric analysis of all the scientific articles published between January 2014 and June 2016. So this is over a 60-month period, but for this research, they actually focused on the first 30 months instead. And this was looking at 4 prominent journals. So from that, there were general medicine articles, which were used because they're widely read within the global health community and also have a broad influence. And also global health related articles as well, or journals. And these are more likely to be published from low income or low middle income locations, and that's why they were utilized as well. So these journals were used because they have a high impact factor, and I'll show you in the next slide which journals were actually introduced to actually view all the articles related to low middle income countries. So each article had they had to review the study location, the topic, the author affiliation as well, and they all had to be original research articles or research studies for the analysis. So in 2014, there was quite a lot of publications regarding Ebola, and these were excluded just to help to optimize just a generic background for the articles that were looked at. So these were the articles included. So in 2014, 2015, 2016, from the general medicine side of things, New England Journal of Medicine, the Lancet, the Journal of American Medical Association, and the BMJ, British Medical Journal, were all included. So these were the 4 from the general medical journals. And then there were 5 from the global health journals. So these were the Lancet Global Health Journal, Bulletin of the World Health Organization, PLOS 1 Global Health, American Journal of Tropical Medicine and Hygiene, and Tropical Medicine and Internal Health. And you can see, particularly with the general medicine journals, they had quite a high impact factor compared to the global health journals. So we go on to the results. So there were 878 articles in the final analysis, and of those, within the African region was the majority of the articles. So in the African region, 46% of the world's low middle income countries are found there, and 24% of the global low middle income country population is within Africa. And 49.9% of the publications were related to the African continent. And of those publications, 26.2% were based in 6 East African countries. And those included Burundi, Kenya, Rwanda, South Sudan, Tanzania, and Uganda. And then with the Southeast Asian region, these represent 11% of the world's low middle income countries, and also 53% of the global low middle income country population within the year of 2014. And so 13.6% of publications were based within Southeast Asian region. And then the last region that was seen was also the Mediterranean region. And so they count for 11% of the world's low middle income countries, and also 12% of the world's low middle income country population within the year of 2014. And of that region, 2.2% of publications came from there. So we'll go on to the various figures and tables as well, just so that we can see exactly what was found from the research. So this is a figure which shows the distribution of global health publications per 100 million inhabitants based on the WHO geographic regions. And so you can see the vast majority really are from the African continent, which has 55 articles per 100 million inhabitants per year. And then this is followed by the Eastern Mediterranean region, and then the Southeast Asia, actually followed by the Americas, then the Eastern Mediterranean, then Southeast Asia, and then the Western Pacific. And you know, it's really reiterating the fact that quite a lot of research comes from the African continent, which is quite an interesting point for discussion. And then this further elaborates this as well. So it's another figure which shows the world map. This time there's a focus on the average annual distribution of global health publications, and the red dot, the larger it is, the more publications were within that year. And so you can see there's a huge emphasis of research within the Eastern African region and also within West Africa, but less so. And you can see the Southeast Asian region does have some research going on as well, and not so much really in the Americas or the Far East Asian areas. So then we'll go on to the author affiliations. So I've just kind of highlighted or put a square around the key thing really to discuss, and that's the corresponding author being exclusively from a low middle income country. And you can see that actually it's not a great number. Within all the journals, 176 of the publication people from the publications were first authors, and that's out of 876. So that's 20% of all publications were actually from low middle income country authors who were the first authors. I hope this all makes sense. And then you can see the other categories as well, which is the corresponding author joint. So essentially the low middle income country author along with a high income country author. And then the lowest one is the fact that the low middle income country authors were actually second or third, or you know, a bit later on in the authorship of the article. And you can see that this is actually the majority of the cases throughout the year of 2014. So 71% of all the articles published within these high impact journals were including authors from low middle income countries who weren't the primary author or the co-author of the article. I think that's a really important point to highlight as well. And you can see the distribution as well between the general medical journals and also the global health journals, and they're quite comparable really. But again and again, it does seem to show that a majority of all these journals throughout the years does have the other author as someone from a low middle income country. And then this goes on to show the analysis of the study populations and the subjects included within the articles that were analysed. So majority of the articles or the research within the articles were based on the adult population. And also the majority of the subjects included were regarding non-HIV infectious diseases at basically 40% of all the research. And there seemed to be a greater emphasis on within the global health journals on infectious diseases compared to the general medical journals, which also included infectious diseases, but had more so input from the non-communicable side of things as well. Okay. So in terms of the discussion, it does go to show that there's an overrepresentation of scientific studies, particularly from the African region within East Africa, compared to the other regions such as Southeast Asia and also the Mediterranean. And there was also what was shown to be the corresponding LMIC authorship, which is very limited. And there may be a few things that could be causing this, which was discussed within the article. And that could be the possible, the possibility that there's reduced awareness of authorship criteria for low middle income country partners. The authors may be from working within the low middle income country, but have multiple affiliations and choose the high income affiliation instead when publishing their article. And there may actually be no local collaboration, which has led to no low middle income country authorship as well within the article. And as I said earlier, there seems to be a strong emphasis on infectious diseases topics in all the journals reviewed. So in terms of the limitations, there were several things that were found within the article. So the selected journals were widely recognized among the global health practitioners, but they weren't specific topic journals such as infectious diseases or anything like that. So there is a scope for there to be actually not as much information as there could be if the other journals were included. The second thing is that there are two global health journals which lacked impact factors, and so this may actually, and they were included because their parent journals had a high impact factor, and so it wasn't really as useful as it could have been, I think, from what they were saying in the article. And also the impact factor is a marker for the journal influence, but this also limited the amount of journals that they would review, as in total they looked through 9 articles, 4 from the global health side of things and the 5 from the other side of it. And so it's may have been better for them to include a wider scope of journals, both really actually covering general global health and also specific topics as well. And then, as stated beforehand, it was covering from 2014 to 2016, a 60-month period, but the results were only included regarding the first 30 months of from 2014. And so it may be useful to have a second analysis regarding the following 20 months of the analysis. So in terms of the conclusion, the articles analysed had a high impact. Essentially the article was to review the articles that were regarding high impact global health research within low middle income countries, and they wanted to review where it was conducted and who was receiving the credit for it. And their finding was that there's an ongoing imbalance regarding low middle income country corresponding authors versus other authors. And so there is a risk of promoting similar and overgeneralized and disproportional research. And this is something that we would actually need to actually discuss. And there's a need for greater input from low middle income country researchers to mitigate this. So this leads on to 2 discussion points that I wanted us to go over, along with just discussing the article itself. So what has been your experience regarding low middle income country research, and how can we optimize low middle income countries authors getting first authorship for scientific research? Okay, thank you. So anyone want to start the discussion? So I'll just check through the chat box to see if there's any questions so far. And I think there's something from Rima, which said it would be interesting to hear the thoughts of participants here that are from low middle income countries, what all of you think are contributing factors and how we can address this. I think that's a very good point. Any takers? Dr. Noel, did you have anything to add as well? Feel free to unmute, guys, because I do understand that it's more so a webinar format, but I think it's very useful for us to actually discuss this, as this is not just an article to talk about, but actually to discuss how we can optimize this and ensure that low middle income country research is really pushed forward more so than it is at the moment.
Alliance, what is your experience?
Hi, Rima. My experience has been varied in this. I think this was a discussion we were having last week at our journal club here at my training center, because I brought up the question that we are discussing an article written in Malawi, but first authorships, corresponding authorship, and then senior authorship were going to somebody from a high income country, whereas the study was done in Malawi. So it's a constant discussion to ask, well, why is this happening? What are the factors? And to also make sure that there's no, that the discussion is objective, because we have to try to find out what are the objective reasons and how can they be resolved. So, personally, I think one of the key elements that could bring about would be, well, who decides? One is equitable partnerships, because I know we're talking about collaborations, but are the collaborations equitable in all ways to promote both the high income and the low income collaborators in the research? So equitable research. The second question is, I have in my mind is maybe the research agenda. How is it decided? Because I think that would contribute to either low income researchers not feeling not interested maybe to take leadership in the research if it doesn't answer a question that they feel needs answered. On the other hand, also maybe if funding is coming from high income, the funder might have an agenda that has to be followed, and again, criteria of funding that maybe a high income author has to be the one, taking ownership of the research. So just two thoughts we can discuss about maybe the barriers to authorship for low income located researchers.
I think that's really interesting, because in a way it's a two-way ownership process, isn't it? Sometimes I sort of feel like, whoever wants to do the research from the high income country with the support of low income country trainees, it should be part of their application process for grants, etc., to make sure that the first author or corresponding authors or co-authors are from the countries that these people are going in to do the research. So in a way, ownership should be on the people who are conducting the research. But equally, I appreciate that, when you're working clinically in India or Africa, or, research is not necessarily a priority when you're working 12, 13 hours a day, 7 days a week. So it's interesting what you say. And I think the solution is probably more complex than we sort of appreciate. Maybe.
The cat was also saying, should there be a requirement at the points of ethics of application to describe the collaboration between HIC and LMICs? And I think that's a very good point. It just really, I guess it depends on the ethics committee whether they believe that that's actually relevant to the research itself, even though ethically it would be best. Is it something that they see as the main thing to worry about, really? I think it's a good point to make. And
so
also,
they need to target the actual ethical organizations who are approving, to say, actually, the ownership should be on you to make sure that when you're approving, you are approving the right projects, maybe.
And then Aruthi also said, there are various research institutions based in LMICs. Maybe they should take a lead in promoting research to local institutions and offer special fellowships. I'm not too aware of all of them, but I am aware of the King's partnership, and I think there is more of a collaboration there between the King's and also the local institutes as well. So I guess it depends on which collaborations are being made, whether it's more top heavy or if it is something where it's quite an equal bit between the two. But yeah, that's also something valid to discuss. Anything else, guys?
If I can say something, do you hear me?
Yes, thank you.
Okay, Rima said something very important, something like it's not like our priority, and that's really an important point, because from medical schools or medical studies, we do not have the culture of research. They do not teach us how to make it. They do not teach us how to. We do not have a leader. We didn't have it. It's now that people are starting with the global surgery history and everything. People are understanding that it's important to make research and things like that. We did research. It was made, I can say the same thing, but about anesthesia. We how do you say that? We conduct a research with a team of trainee and other people, where we found many things, and we could notice that the other thing is that the journal, people read on journal with high impact factors, and here, because we do not have the culture of research, because sometimes it's very expensive to be affiliated to a journal or to an institution, it's like, I think these are some of the problems we face here to make these things. So that's what I can say, and what I can propose is that we are at the right place. We are the one. We should raise the problem. We already start with sorry, I'm not very good at it. Advocacy, research with decisions, with national working group, with decisions, making awareness. In fact, we are the one who should make it. I think Alliance understand what I'm saying, because it's in an environment that he can really understand what I want to say. So that's what I can say, and that's what I can bring as proposition. So I think my responsibility is to advocate for that, and I hope I will make it.
Do you know what I think might be a good
practical point to come from this actually is, you know, like you've said, Leonid, it's quite interesting to see that, you know, it's not something that is taught well in medical school where you are. It's not something that's emphasized, and it might be useful if, you know, if there are members on this call who want to start setting up a small sort of teaching type thing where, you know, we can help try and recruit someone to maybe teach ad hoc about research methodology to medical students, because of course they are the future, right? So everyone on this call, I think, has realized the importance of research and why we need it, and the importance of equality. But I guess going forward and looking at the future, it doesn't have to be anything big, but I guess it starts from us and our responsibility as individuals to impart the wisdom on the future generations. I know it's easier said than done, but that's definitely something that I'm sure a lot of GASOC members, etc., would be keen on. I don't want to commit to anything because I'm not, you know, but I think it would be quite useful to, if those who are interested, to maybe email Delphine going forward, and then we can see how we can create a tangible solution.
Yes,
Have I just committed Delphine to something? Sorry.
Sounds great. That's the whole point in this discussion, really. We need to actually, you know, because obviously this article is highlighting something, but there are a lot of things that are going on in the background regarding how these articles get even published in the first place. And Leonid, you've made a very valid point about the fact that medical schools within low middle income countries don't necessarily have that idea of publications and research compared to when we, you know, study medical school in the UK. That's one of the things that we actually think about when we're, you know, studying in school. So yeah, it is very important to help to bring that culture up as well. And it may be useful for us to get Incision involved as well with this, because I'm sure they will find that really interesting as well. But any other points as well?
Anyway, I think the thing it's already going, because you can't spend a week without having a WhatsApp group, some things like please fill this form for us, we are doing this research or this or this. So I think things are moving, but there's still a lot to do. We are going to do our best.
Mm-hmm.
I'm sure going forward, GASOC will really like to advertise and encourage anyone who wants, you know, who's already doing it, so that we can get more and more people involved. Even if it's not us doing it, we can really help advertise whoever is doing it to try and encourage more people.
And also, Kat was saying that maybe we should put pressure on journals to reduce open access publication fees for low middle income country authors. And I think that's a very useful thing that hopefully, you know, if we find a way, we can help to push that forward, and that would help to limit the amount of obstructions that are in the way to getting publication. And then we've had a point from Dr. Pasvik, and he says that most researchers in low middle income countries are practitioners, and they spend most of their times in clinical, and also concerning the publications process are so limited for researchers in low middle income countries. Sorry, would you be able to elaborate on that, Dr. Pasvik?
Do unmute or turn your camera on if you can.
So I'm getting the idea that maybe it's more so that there's not a lot of time to be able to do research along with clinical work as well. Yeah, go ahead.
Thank you. For me, as I said, I've have been experienced that during my final work as a medical student. I was doing a study concerning
That's where I speak.
the global concerning the impact of
You can type it up if you're having issues saying it out loud. But yeah, your input would be really very much appreciated as well. Any other points to make as well, guys? The Alliance has said the advocacy should not just focus on HIC institutions, local institutions from LMIC, universities, Ministry of Health, research groups need to invest more in their local researchers and also ensure more equitable partnerships in terms of research. Yep, that's very true. I guess it's deciding how we can try and advocate for that as well as an organization, whether we need to have an event where we promote this, where we liaise with an organization that tends to do this type of thing, where they collaborate with local institutions within LMICs. But yeah, it's a very valid thing that would help a lot with improving research from low middle income countries. Okay, so the aim of the last bit of this journal club was just to get more of a discussion going, but it's understandable if you're not able to help with the discussion. Dr. Noel, did you want to say anything at all?
Hello to everyone.
Hello.
Thank you. I start by appreciating this interesting discussion. And I am so grateful for the invitation. So I think as others have been saying, research is not a priority in our LMIC countries, probably because of many reasons. Maybe people have competencies but do not do research because there is a lack of motivation, probably. And second, there may be a problem of sponsorship. Some researches are so expensive, and people, even those who have the courage to do them, but are missing enough money to do the research. And three, maybe there is a lack of facilities to do publication. Someone may have done kind of research, but is not finding where to publish the research. And I think there is a need of investment from universities, from medical faculties and the governments, maybe, to support people who would like to do research. I think it is time for our countries to do something. And this meeting is very interesting for me because it is helping us see that there is something, there is some gaps in research. Thank you for listening to me, and thank you for this meeting.
Thank you. So I've just noted it down. I think what I'll go and do after this meeting is actually write down all the key points that we've discussed, because it may be interesting for us to have a list of all the things that we've actually collated from discussing this article. And it's not just saying, oh, this article shows the lack of research here, but actually, okay, what is going on? What's the background behind this? How can we actually help to improve it and implement something that can optimize it? But yeah, if anyone has any further points, please feel free to say something. Otherwise, we will close the Journal Club very soon.
I guess one other interesting thing to me was in the consequence of having very little authorship and even few publications, global health from the LMICs, that 2 points are brought out which are true. One is underrepresentation of pathology that we see in the LMIC region, and so also underrepresentation of our approach to those pathologies, because in our practice, for example, GASOC cases in high-income countries, for those who've worked on the pediatric surgery ward, could never be treated without parenteral nutrition. In my world, never use parenteral nutrition, they survive. So there's a chance for our work here to influence work in high-income countries, but also to not to challenge, but to bring a different view to what is presented as standard of care. So we need more research from our setup to be able to really be our pathologies and our approach to those diseases to be well presented. The other thing to note is, for me as a global surgery advocate, is that generally they found very more, I think, little to no global surgery related publications in the global health world, which I think is still, again, surgery coming out as a, the neglected stepchild. We need to really promote as global surgery. To those who are new to it here at GAS, it involves both surgery, anesthesia, obstetric care. So we need to step up our work in the global surgery research to promote that as well. Yeah, so those are also my other thoughts from reading this article.
Okay, thank you. So we'll just close off. The first thing that I just want to say is that thank you for everyone's discussion. We will write down a summary and we're going to send it off as email. If everyone's still happy, then we can also publish it on YouTube and hopefully get a discussion going there as well. The other thing is we do have our upcoming conference, and I will share the screen just to show you. So it's based on the story of global surgery, past, present, and future. And we just want to invite you guys to it. The website I will put in the description in the chat box as well. But we're still getting all the speakers ready, and it will be in September. Let's see if I can cross it down. Yeah, so it'll be the 18th and 19th of September. It's going to be online, and the sign up is available if you want to as well. And if you want to join us on the mailing list as well, we'll try and get that sorted out for you. And we'll be sending feedback forms so that you can actually let us know what you thought about this session and how we can improve as well. But yeah, thank you so much for joining us. And we hope that you found this really useful and was able to come up with something else from this journal club as well. But yeah, thank you. And have a lovely evening, guys. And we hope to interact with you very soon. Okay, bye.